Okay, so good morning everybody. After a very interesting discussion about various advances on this field, we'll now invite our panelists to come on the dais. I invite Dr. Cohen, Dr. Tadej, and Dr. IPS Kocher to kindly come up on the dais so that we can start the panel discussion. Please. So we have been, that will be better, I think. You'll be able to see it from there also. So we have witnessed a lot of changes over the last 2 decades in terms of diabetes management, and we have discussed so much in terms of what has happened and how we can improve the care of these individuals. So is it the end of the story? Are we really into an age when nothing more can happen, or there's something else we aspire for? The lives have changed dramatically, but is there anything which can really change now? And every time when we have somebody who says that, okay, the time has come, that every development has happened, there's nothing new that happened, one is always reminded of this quote which says that everything has already been invented in maybe 120 years ago. So we can never say no, and we always will aspire for better, no matter how physiological the control has already been achieved. So what we'll try through the panel is to see what is going to happen and maybe go through the crystal ball in terms of management of diabetes. Now the key questions or the key problems we want to address at the moment in terms of type 1 diabetes management is to predict the disease at the right time, then to prevent it once we have predicted, followed by possibility of replacement, and finally a complete restoration. And this is what we are aiming for. So we'll go one by one on all these issues. The framework is that there's going to be a case-based discussion. We will have interaction with the panelists. We'll check out what is the current status and how we will go forward in this direction. So let's start with this case, a 7-year-old girl with type 1 diabetes, and she was diagnosed with DKA. She has a younger sister who is 4 years old, and parents are really scared because older girl has developed diabetes and DKA. They don't want this to happen with the next child. Now, Dr. Tadej, can there be a way in which we can predict and possibly prevent this child from the sister? So this is a sister they are concerned about in terms of development of complications and type 1 diabetes. So in this case, what is the current status in terms of prediction and possibly prevention from that perspective?
Thank you very much for this question. Again, it's my first opportunity to thank the organizers for this very kind invitation. It's my second visit to India in 14 days, so you can imagine I really like to come. So what we can offer now, young people and families with type 1 diabetes, as you know, for a long time, it's the American network, actually, that provides under Jay Schuyler with funding from the National Institutes of Health and the JDRF, a very large screening throughout the world. And I do believe an Indian center also participates, correct me if I'm wrong, but I do believe there is one center in India, in screening family members for positivity of antibodies and for the risk of HLA-related components. And for many years, actually, as you know, none of the trials were successful. So it was basically more or less a lot of money and effort spent in gathering samples and data. But then, if you please go ahead.
So this child was further worked up in terms of the antibodies?
Yeah, so the usual thing that we do is we screen for the 3 antibodies. Now there are more, a little bit more. Maybe there are 5 now. We rarely, so the Americans did the first phase insulin release, but this is rather, as you know, rather invasive. So newer trials that I will mention actually do not use this unless inside an intervention trial already. And you can say actually the risk, but even if you have only antibodies, the 3 antibodies, positivity and the HLA, you can predict with more than 70% security that in 5 years these people will develop diabetes. And
so now the next question is,
obviously everybody, not only parents, actually even myself after 30 years, I am sick of diabetes. I want to prevent it, obviously. It just doesn't work. So it's not only parents, actually. I believe that all of us are very much on the same line. But then I would like to draw your attention to this publication that I'm sure you all saw from the New England Journal of Medicine this summer. And this is probably the first time, actually, that you can seriously postpone the onset of diabetes. Actually, these children that were enrolled all were positive, and some of them already have impaired glucose tolerance. So they were quite in an advanced stages of diabetes. And as you can see, actually, teplizumab was able to postpone, on average, for 2 years, the beginning of type 1 diabetes, which I believe is an amazing result. So this is an American trial, and in Europe, we have the INODIA initiative. INODIA is a publicly funded grant that also has actually financial input from the JDRF, from the Helmsley Foundation, and from the industry. So that's good, because also industry that basically earns with diabetes is ready to participate in diabetes prevention. I think it's a very good move. And there are now 3 studies ongoing inside the European Union with teplizumab 1 in newly onset, so it will be different from this one. We will test the newly onset. And there is an anti-thymocyte factor, another substance actually that is potentially successful, also ongoing inside the INODIA, the European framework. And what's important is actually that this was only 1 injection, so 14 weeks of therapy, if you want, initially, and then they followed them up for 5 years with no additional therapy. So just imagine if they would give the therapy every year, it is very likely that the postponement would be longer. So it's a hope. It's a hope, and the side effects are mild. There's a transient lymphopenia that goes away within 100 days. There are some skin rashes, but there was no major safety signals actually appreciated in this study. So there is a new hope. Thank you.
So finally, after so much work in terms of primary prevention of diabetes, probably there's something which we are looking at. There are so many studies which are ongoing, but probably this is one which is providing some hope at the moment. Now, we'll talk a bit about secondary prevention. Again, we have now, let's go to this case back. Go to the case 2 months later. She is now into the honeymoon phase, and her insulin requirement is pretty low. C-peptide is still detectable, and parents want to prolong this phase. So now we talked first about how we prevent in the system. Now the issue is how can we prolong this phase? Is there any intervention which is possible, Dr. Ohad, in this setting to really prolong the honeymoon phase in this situation?
So now we are more into the tertiary part of prevention, and that's when the patient is already has the disease and is this in the honeymoon state, or where there is some partial resumption of beta cell function. By the way, I think it's nanomole per liter, not millimole, if I'm right. But the issue is, first of all, what is a remission? What is a partial remission? How do we actually measure this? This is one question. And what is causing this partial remission? So just briefly, because we need to define what we're trying to help or to persist. So the one way to measure remission will be the C-peptide. Fasting, or after a provocation, after a meal, after glucagon, after arginine. So there's no clear definition, and also we don't want to have a definition that will require the patients or the kids or the adults to go through a meal test or something that needs to be done in a hospital and so on, as Tade just mentioned. So moving away just from measuring C-peptide, now we're looking at more general way of assessing, and that taking into account also the insulin dosage and the A1C of the patients and combining them together. There's many ways to define it. So we define it as a complex picture of both C-peptide secretion ability and A1C and the amount of insulin that is required. Now, what's different between trying to prevent or trying to persist or to increase the time of the honeymoon? It's very hard because there might not be the same underlying pathogenesis for these two. And since it's not known, let's not go into more details, but to say that some of the ways to increase the honeymoon period is going back to the major reasons that's just been described. That is giving some interventions on the immunological side. On the other hand, what's really is the major proof that you can do something to persist the honeymoon is by better control of the patients. And this actually came out of the DCCT. The DCCT group that was treated more intensively were the ones who showed a persistent C-peptide of more than 0.2 nanomole per liter after a couple of years. Hence, I would say from a practical point today, the issue will be one, improvement and persistence of better control. That is why we do not stop insulin in this period, but continuing insulin. There are now, from a technological point of view, that's where I'm going to end, believing that more technology might cause a more better control of glucose. There has been several trials trying to start once at onset of type 1 diabetes using both pumps and sensors. I have to tell you, not many of them were very successful. And the reason is maybe it was not tight enough. And for the future, currently there are studies using the artificial pancreas at day 1, looking will that be able to persist the beta cell function at onset.
And would prevention of decay potentially help in terms of prolonging this phase? Does decay have a bad effect to begin with on the beta cell mass, let's say? So if we are able to prevent decay, would that also result in a better presentation?
Present DKA, and also, and I would say, add also, for this reason, they're also pushing exercise and in order to improve and reduce DKA to persist the honeymoon period.
Honestly, since we are in India, actually, if you, as Indian colleagues, are able to put together a teplizumab trial, I wouldn't, think this was a crazy idea. So teplizumab for a study, I'm sure the company would be happy to assist you. So, you have a lot of people, a lot of excellently educated physicians. You have large centers. Why don't you start your own teplizumab trial? Because, it's impossible to enter the NIH environment or the FDA environment or the EMA environment. But you can do an Indian trial if you do it properly. And this would certainly, in this stage, be my recommendation to you.
Yeah, I think so. The key message coming out here is that diabetes control probably remains the most important metric in terms of prolonging the honeymoon phase. Trials are there, and probably we can expand evidence on that, but probably stick to the initial control and don't stop insulin would probably be a situation. So hit hard, hit early, control your sugars well. Now 3 years later, she is on a basal bolus of 2 units per kg per day. She has become a bit overweight, obese. HbA1c is still high. What are the possible non-insulin options, Dr. Kocher, in this regards?
So actually every child in India, the first question the parents ask is there anything possible besides giving insulin to the patient? So have you any non-insulin options? Because how many pricks my child will take? So there are various non-insulin. It all starts with glucose intake. When you take glucose, sugar from glucose gets absorbed from the intestine to the body. The liver also plays a role. It passes glucose into the blood. There is a muscles, striated muscles, where the tissue uptake of glucose there. Then there is in the kidney where the excretion of glucose is occurred. Then there is a GLP-1 peptide which gets excreted from the intestine and acts on the pancreas. And there it has GLP-1 agonist. So they are all, and insulin and glucagon. So all these things there are certain drugs which act on various parts of the system, so in order to control the sugar levels. So one by one, if we take up the glucose, metformin, there's one drug which is being used, it decreases the glucose release from the liver. So that's one thing. Then the second, another drug which is there is, and if we come up to the insulin and glucagon, sulfonylureas require insulin, but since insulin is not present, so it is obsolete. We use sulfonylurea in this population. Glucagon, yes, secretion of glucagon, if it is, it increases the sugar. So if glucagon can be decreased in such a way that some drug which will act on glucagon, and then that is a GLP-1 receptor agonist. So that can also cause this. Then there is some drugs like thiazolidines which act on the striated muscle to increase uptake. There are drugs like SGLT2 inhibitors which act through the kidneys to excretion of sugar from the urine. So taking all these drugs into consideration, maybe you can use metformin, an SGLT2 inhibitor, and drug like GLP-1 receptor agonist in cases of some may have some role in type 1 diabetes, but most of these drugs are, I would say, not actually really recommended because there are still trials going on, and they may be, decrease the dose of insulin, or they may decrease, like metformin and thyroxine may decrease the weight. And they may be just an adjunct. Can I have the next slide, please? Yeah. So they may be just an adjunct to the whole treatment of, using of type 1 diabetes. But still, it's just like you can say in fiction that these drugs are available besides insulin, but we need a lot of work still to be done to say that to use in type 1 diabetes.
I just have a word from Dr. Tadej regarding the use of sotagliflozin in type 1 diabetes and possibly GLP-1 analogs. Would that be of help? Dr. Tadej, can you please come in?
So if you come to my lecture on ISPAE guidelines, I will discuss it, and the reply is yes.
Okay. So there is still
but
insulin.
I think FDA just 2-3 days back has recommended that no SGLT2 inhibitor should be used in type 1 diabetes.
This is wrong, actually. They just approved the first 2.5 milligram dose a week ago, the FDA, right? And the EMA approved 2 drugs for the use above the BMI of 27. So it's approved in the European Union, and very recently it's improved in the United States.
So
Not for children, of course.
Yeah.
Not for children, above 18, but do we care?
I think we're talking about the pediatric adolescent population.
Yeah.
The message is not to be used till now. So when maybe above 18, yes, it's approved.
And since we're talking about crystal ball, so probably SGLT2 inhibitors will come maybe next time when we have the ISPAE. By that time, the experience would have been approved on that. But that's a very good point, Dr. Kochhar, in terms of the safety issues. Now, 5 years later down the track, she has been on pump with intermittent CGMS, fluctuating sugars. She has heard somewhere about artificial pancreas. So what really is artificial pancreas, Dr. Ohad, and are we really there, or will we ever be there?
So how much long do I have to? In 2 minutes.
2
okay.
minutes, yeah.
So the answer is why does she need artificial pancreas? And the reason is that all the therapy that we're treating them today by pumps, sensors, SGL2s, you name it, we are unable to reach the euglycemia that we want because we are not answering the main issue is the variability. I think Tadej always points out that the sickness of type 1 diabetes is the variability. And all our measures today, our drugs, our concepts, are not addressing the variability. The only way that we believe that can address variability is by treating the patient's glucose as they need at that moment, individually, in real time. And we have not reached this stage until 2 years ago. 2 years ago, the first artificial pancreas device, or it's not a good name, but let's call it hybrid closed loop device, came into the market and has been shown consistently to reduce the variability, the disease of the variability as just defined by the time in range. So I would say in this day of age, I think we're already going to see that data-driven glucose coupled insulin delivery will be the state of the art of the treatment of type 1 diabetes, and will have Sita, what's her name, be better controlled for long term with less cognitive and future comorbidities of type 1 diabetes.
Do you think is there any role of bihormonal agents like addition of amylin or glucagon in that?
So the question of glucagon, it's like from an engineering point of view, it's very, very, very difficult. Why? Not the complexity of another hormone and another chamber. The issue is when you define, if you want to have a very fast car that is built that you, on onset, you put a lot of gas on and you just work with the brakes, it's not going to be as stable. Because what happens if the brakes does not work? You are with insulin driving to a wall. So engineeringly, just basing on higher insulin dose and relying on glucagon for salvage is quite dangerous at this stage. That's why most of all the companies right now that are working on a commercial safe device are using only one hormone at this stage. But this might change in the future.
Okay. So now, at 15 years of follow-up, she is really sick of everything, insulin, glucose monitoring, and wants cure. So what are the options here? So options, of course, are we talk about mechanical options in terms of using pumps, artificial pancreas, or we talk about biological options of cellular transplantation, pancreatic or whatever. So what do you think, Dr. Tedej, is the current position, and what do you anticipate in the next maybe 10 years or so in terms of both mechanical versus biological treatment or cure, let's say, of this situation?
So number one, we have to be clear, and this was also the ISPAE position, there is no cure at the moment. So people are confused with bone marrow transplantation trials in Brazil that were completely unregulated and uncontrolled. People are confused with stem cell infusions that are ongoing in Russia and in Ukraine and are China, closer to you, thank you, and are completely uncontrolled. They are not successful, and there is no cure. So people should really save money, actually, and the health of young people not participating in these initiatives. Saying this, actually, there is a huge amount of research and work in expanding the beta cell availability, because the limiting factor of islet cell transplantation, as you know, is the availability. And there is huge research, actually, in protecting beta cells from immunity to replace the need of immunosuppression. And there are significant advances. There are now chambers, some of them made out of lungs and other, live tissues, some of them being completely artificial. And basically, I believe there will be a path in replacing either engineered beta cells or real beta cells enveloped in something that protect them from autoimmunity and implant to people with diabetes. So there's this obvious way that we should follow and we should pursue, and there are big people, very big people, and a lot of money behind. So I think there is hope. Well, the second obviously way is that we try to understand type 1 diabetes. As soon as we understand why it happens, it will be considerably easier to treat it in a more, physiological way. The only thing we have at the moment, and I'm sure that the reply from Ohad Cohen was clear, yes, we have a closed loop. We have 2 closed loops, actually, on the market, and I will discuss this, and we are expecting several more, with which I hope the price will go down. So it will become more available to people with diabetes. So it should be a very clear reply. We have a closed loop. We have 2 closed loop currently. A new one is coming early next year from Medtronic that seems to be considerably better than all previous. So the only question that remains is, can we afford it, right? And this is a good question. And there is also another question. If you just throw the closed loop to people with diabetes, it doesn't work so well. So they need additional training. With this, physicians need additional training. So it's a whole process, and the sooner you initiate this process in India, the better will be for your people with diabetes.
So I think probably it's very exciting that we may have bioengineered beta cells which are put in an encapsulated device and transplanted, safe from immunity, getting oxygen and glucose. So this would be probably the way for the future. So now we'll talk about the various options, and every time we say there is no cure, but patients want to know about a lot of cure options, and they have heard something about the possibility, Dr. Kochar, about the various strategies like pancreatic transplant, like islet cell transplant. What is the current situation would you like to recommend? What is the current situation in that regards? Because
so as far as the restorative studies are concerned, there is pancreatic transplant, there is islet cell transplant, there is stem cell transplant. So as far as pancreatic transplant, most of the time it's being done in adults where they have already had diabetes for the last 20 years. And they like to do it when there is renal failure, ERSD, so that they do both the transplants together. And the main problem is immunosuppression. Carrying on immunosuppression for lifelong is a big, big problem. So side effects of immunosuppression, all that. And islet transplant, there are various protocols. One is the admit protocol, they're modifying it. Again, the question of suppression, and again, rejection of the new islet cell transplant which has been done. The same autoimmune phenomenon will occur in this also. So to prevent that, immunosuppression will be given for a longer time, to keep in remission for a long time. Second is that, most of these studies have shown, that like one encapsulated, which just Dr. Anurag showed you, that putting it and keeping it in transplant. Islet transplant is very easy, but the problem is getting the islet cells. You need a lot of pancreas, and there are not a lot of pancreas tissue available to get the islet cells. Stem cell therapy, still very experimental, lot of noise, lot of works people are talking about the stem cell, but still very unexperimental. We don't know these cells which are being used for stem cell, whether they are causing cancer in the future, causing anything. So as Dr. Cohen mentioned, that we should still hold on, wait. It's still unproven. Do not talk about it, do not mention about it, and try to make people understand that till hope comes about stem cell, we should just keep it as experimental and not as a treatment as such. So in the end, it's just to say there is no treatment like this at present for type 1 diabetes under 18 years of age.
I think this is the key message, that probably the elusive cure is still not there. I am still reminded of what Professor George Werther used to say in 2008 to the patients, that when I was a student in 1980, we used to say that in 10 years a cure will come. And this is what we are seeing in 2008. So you don't hold on to a possibility of a cure, and this is something which has come up, but there have been tremendous advances which have happened, and the management has changed dramatically in the last 10 years, and I'm sure a lot of new things are going to come up. The key things definitely is the prevention, probably with teplizumab, the possibility of newer ways of preventing the beta cells from getting destroyed would be the way forward. So hopefully next time when we have a conference, both of you can come and share us about new things that have developed and we have improved the children's lives. I'd like to thank all of you for patient hearing. Thanks a lot, Dr. Ohad, Dr. Tadej, and Dr. Kochar. We have got maybe a couple of questions only.
I have a question for Tadej. Two questions. Actually, one comment, one question. The Protege trial, I was one of I participated in the multi-centric trial in which teplizumab was used in burnt-out diabetes cases, but they used HbA1c as an endpoint, and since after a year they couldn't meet that trial was shelved. So that is the comment, and the question is, what is the status of this artificial pancreas? As we heard in the United States, they're going to roll it out where you have the chip which gives the basal as well as the bolus. What is the status on that?
So I agree with the first part. We need different outcomes for these trials, and the outcome likely will be time in range. The FDA is discussing this. I don't know what they decide, but it's in the air. And for the second one, actually, it's very good news. So there are two systems now that deliver the basal rate and correction boluses automatically. They are both actually, so one, I will show you, was just published in the New England Journal, and they filed for the FDA. And the other one, there is the pivotal trial ongoing and an NIH-sponsored trial ongoing, and there is a belief that it will have the CE mark in early spring in the European Union, and not a lot later the FDA clearance in the United States. Was I correct?
You know more than me, but you're correct.
Okay. Okay, so we will have two systems commercially available by early next year. New one, and both delivering basal and automated correction boluses.
I think
Just add one thing, is that what's positive about the data coming out from these systems, wherever they are, is the consistency in the results. So what you see in the pivotal, in the small trials, you can see consistently when you go to national data, national registry, that gives you more confidence in the concept that the chip and the algorithm is better than us as doctors, but in a persistent way.
I think thanks a lot, everybody. We'll close the session here. Just a couple of, we'll take the questions later because it's already short, no time here. Just a quick announcement. Everybody who has the e-poster to present today needs to load it in the area where the display is there. And I think we'll break for tea now. And we'll hand over to the organizers. We'll join back again at 12 o'clock sharp with the next session. Thank you.